Assalamualaikum warahmatullahi wabarakatuh. So,
Waalaikumsalam.
okay, now it's already 8:06. We only have 36 of you. I know that it's not enough yet, but I think we shouldn't punish those who are on time. Okay, all right. Before we begin, just few reminders. Okay, let me do something. Okay, just few reminders. The first thing is the account that we're using is my personal account. This Zoom account. This is my personal account. It's been basically I paid for this monthly, and so and it's recorded. It is recorded, and we upload this to YouTube. Why we upload this to YouTube is so that because I know some of you don't have good internet connection and things. So the idea when we upload is that so that you guys can review the videos next time. Okay, so that's one thing. The second thing is I really hope that you guys can sometimes when you present cases, one thing I hope you guys to do is actually to be careful with personal identification. Meaning such as when you present cases, so make sure that you do not give any identifiable information. Okay, all right. And then the videos are all available in pediatric department's YouTube channel. You can view them and actually learn more from them. There's videos from other groups as well. And please don't use this for personal chats. We've had before student guna our Zoom channel for personal chat, discuss nak pergi beli apa, nak pergi makan mana apa semua. So it won't appear good when we upload it. So please be careful with that. Okay, clear. Can you see my video? Oh no. Can you see or not?
No, doctor.
No, doctor.
No.
No.
Let me see why. Just my other format. Okay, let me do something. I don't know why my camera is not working. Okay, it's alright. Okay, let's begin the session. So who's going? Let's begin the session with Kitab Al-Fatihah. Okay, alright. So who's the first presenter? Tafadhal.
Okay, me, doctor.
Okay, start.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And a very good morning I bid to Dr. Syed and also my fellow colleagues. So today my group will be presenting a seminar about virology. So this is the topics for our seminar today. So my name is Abdul Hazim bin Muhammad and I will be presenting about infectious mononucleosis. So this is the outline for my presentation. So for the overview, infectious mononucleosis is a clinical syndrome characterized by fever, lymphadenopathy, and also pharyngitis. It is previously known as glandular fever. And the primary cause of infectious mononucleosis is Epstein-Barr virus. So this virus can infect B lymphocytes and it is transmitted by salivary secretions from child to another child. For the etiology, Epstein-Barr virus is a double-stranded DNA virus, which is a member of gamma herpes viruses. This virus causes about more than 90% of cases of infectious mononucleosis, and as many as 5 to 10% of mononucleosis-like syndrome is caused by other organisms such as cytomegalovirus, Toxoplasma gondii, adenoviruses, hepatitis B and C viruses, and also HIV. So for the epidemiology, Epstein-Barr virus can infect more than 95% of the world's population, and it is spread by salivary secretions or intimate contact between susceptible persons and EBV shedders. Some studies also shows that this virus can spread through sexual contact. So, EBV virus that acquired during childhood years is often subclinical, which is only less than 10% of children will develop clinical infection. The peak incidence of infection has been described in the range of 15 to 24 years of age. So this is the pathogenesis of infectious mononucleosis. You can look at the gray boxes. So the first one is the virus is shed in the salivary secretions, and then it is transmitted to another person, and the Epstein-Barr virus will make contact with the epithelial cell and infect the oral epithelial cells, and then the virus will be replicates and eventually will infect the B lymphocytes in the oropharynx, and this will give rise to the symptoms such as pharyngitis. And then there will be two types of antibody production, which is IgM antibodies to Epstein-Barr virus itself, and also heterophile antibodies, which I will explain later. And then the ongoing viral replication will lead to viremia, and then the infected B lymphocytes will be disseminated throughout the lymphoreticular system, including the lymph nodes, spleen, and also the liver, and this will give rise to the symptoms such as lymphadenopathy, jaundice, hepatomegaly, and also splenomegaly. And then after the primary infection, the virus can remain in a latent state in B lymphocytes. So for the clinical presentation, as I mentioned before, majority of infection in children is often subclinical. So the incubation period in adolescents is 30 to 50 days, but in children it can be shorter. So the patients may have prodrome such as malaise, fever, sore throat, headache, and myalgia. And this prodromal period can last about 1 to 2 weeks. So the characteristic triad of infectious mononucleosis is fever, lymphadenopathy, and also pharyngitis. So for the lymphadenopathy, it is most prominent in anterior and posterior cervical lymph nodes, and as well as submandibular lymph nodes, and it is less common in axillary and inguinal lymph nodes. So these lymph nodes can be large and moderately tender, and eventually the lymphadenopathy can become more generalized, which can differentiate it with other causes of pharyngitis. And then the sore throat. The sore throat is often accompanied by moderate or severe pharyngitis with enlargement of the tonsils, and also occasionally with exudates. And also, as you can see in the picture, there will be palatal petechiae can be seen at the junction of the hard and soft palate. And then the patients with infectious mononucleosis who are treated with ampicillins can develop ampicillin rash, which is a widespread erythematous maculopapular rash. And then other presentation includes hepatomegaly and also splenomegaly. So for the investigations, full blood count is useful as majority of the patients have leukocytosis, lymphocytosis with evidence of atypical lymphocytes, as well as mild thrombocytopenia. So atypical lymphocytes is, as you can see in the picture, is a larger lymphocytes than normal with lower nuclear to cytoplasmic ratio. And then the liver function test can show mild elevation of transaminases. And then the next one is monospot test that can be used to detect the heterophile antibodies, which is the cross-reactive IgM antibodies that agglutinate mammalian erythrocytes, but not the Epstein-Barr virus itself. It is positive in 90% of cases in adolescents and adults during the second week of illness. However, it is less sensitive in children, which is only 50% of the it only positive in 50% of cases in children below 4 years old. And then if the heterophile antibodies is negative, but the EBV is suspected, we can use the EBV specific antibodies. This includes antibodies to viral capsid antigens, VCA, Epstein-Barr nuclear antigen, EBNA, and also early antigen EA. However, the most useful antibodies is IgM antibodies to viral capsid antigens. So for the complications, severe complications is uncommon, but splenic rupture can occur spontaneously or following a mild trauma. And then airway obstruction occurs for about less than 5% of cases due to the edema of soft palate and also the tonsils. And then the neurologic complications such as headache is common, but meningitis and encephalitis is uncommon. And seizures can also occur in about 1 to 5% of the cases. Hematologic abnormalities can occur such as hemolytic anemia, thrombocytopenia, as well as neutropenia. And other rare complications of infectious mononucleosis is myocarditis, pneumonia, and also pancreatitis. So for the management, there was no specific treatment for infectious mononucleosis, but the mainstay of treatment is to rest, adequate fluid and nutrition intake, as well as symptomatic treatment to manage the fever, throat discomfort, and also malaise. And the patient should also avoid excessive physical activity during the first month to reduce the possibility of splenic rupture. And then short course of steroids may be helpful for complications such as airway obstruction, but there is insufficient data to support the use of steroids. And then the last one is antiviral therapy is not recommended because it has not been shown to give consistent clinical benefits to the patient. Okay, next I will proceed to Rosella infantum.
Wait. Any question? Any questions from the group? No, clear. Understand. Faham belaka semua. Okay, so one thing that I wanted to remind you all. Wait, my voice is. Okay, one thing I wanted to remind you all is that if you have a child with things like generalized lymphadenopathy, so generalized lymphadenopathy, fever of unknown origin, hepatomegaly, so these are all things that you need to think about infectious mononucleosis, EBV infection. Okay lah, alright. Proceed.
Thank you, Doctor. Next, we proceed to Rosella infantum. So, it is also known as exanthum subitum or sixth disease. It is a clinical syndrome characterized by 3 to 5 days of high fever that resolves abruptly and followed by development of a rash. And then it is also associated with other diseases such as encephalitis, especially in immunocompromised patients. And for the etiology, Rosella infantum are mainly caused by human herpes virus 6 and also human herpes virus 7. But the most yes, doctor?
Hazim, why is it known
Yes.
as sixth disease? Anyone has any idea?
Because it start at 6th day of the fever.
Anyone else has any other idea?
Because it affects for those who are 6 months old and above.
Okay, dia ada few diseases yang cause fever and rash. So Rosella infantum is among them. Dia ada yang kita panggil first disease, second disease, fourth disease, fifth disease. So fifth disease yang kita nampak slap cheek punya sign. So these are all diseases with in children with fever and rash. So diseases in children with fever and rash, you guys need to know. Okay, alright, we'll get back to that. Okay, continue first.
Okay, for the etiology, it is mainly caused by human herpes virus 6 and also human herpes virus 7. Human herpes virus 6 can be divided into HHV 6A and also HHV 6B, which is more predominant. So both of these virus is double-stranded DNA virus and are the sole members of Roseolo-virus genus in the beta herpes virus subfamily of human herpes virus. Okay, for the epidemiology, most infants are protected from this virus due to the maternal antibodies until 6 months of age. The incidence of infection rise as the maternal antibodies level decline, and then about 95% of children being infected by 2 years of age, and this disease occurs equally in boys and girls, and it is mainly transmitted through saliva or respiratory droplets of asymptomatic adults. So for the pathogenesis, it is quite similar to the infectious mononucleosis. First, the virus enter the oral or nasal mucosa through the saliva or respiratory droplets, and then this virus can infect a broad range of cell types such as B and T lymphocytes, monocytes, and also natural killer cells, and they will cause a relatively prolonged 3 to 5 days viremia during the primary infection. And then after the primary infection, the HHV6 can remain in a true state of latency in lymphocytes and monocytes. So this is the progression of the clinical manifestation. The incubation periods take about 1 to 2 weeks, and after the incubation periods, the patient will experience a sudden onset of high fever, which is usually more than 40 degrees Celsius, which lasts about 3 to 5 days. And during the febrile phase, the patient may have other symptoms such as palpebral conjunctivitis, edematous eyelids, acute otitis media, rhinorrhea, cough, vomiting and diarrhea, and also Nagayama spots, which are ulcers that can be seen at the soft palate and also the uvula. And then as the fever resolves, a blanching maculopapular rash will appear, starting from the neck and trunk, and eventually spreading to the face and extremities. So this rash is generally non-pruritic, and it typically persists for 1 to 2 days. However, occasionally it can only be visible for only about 2 to 4 hours. So for the investigations, Rosella infantum is diagnosed clinically based on the characteristic features, which is the fever for 3 to 5 days, and then followed by the rash in a young child. Then laboratory features may show neutropenia, thrombocytopenia, and also atypical lymphocytes. And then the viral culture is the gold standard method to document the active viral replication. However, it is very expensive, time consuming, and not readily available. And then polymerase chain reaction can be used for the detection of viral DNA. And the last one is serology testing, such as indirect immunofluorescence assays and ELISA can be used to measure the antibodies to HHV6 and HHV7's concentrations. So for the complications, febrile seizures are the most common complications of Rosella infantum, which can be found up to 1/3 of the cases. And other neurologic complications is meningitis and also encephalitis. The last one, HHV6 reactivation can occur in immunocompromised hosts and patients who undergone bone marrow transplant. So same as infectious mononucleosis, there was no specific therapy for Rosella infantum. Supportive care is all that is needed for the patients. So the parents should be advised to maintain the hydration of the child and use antipyretics if the child is uncomfortable with the fever. And then in immunocompromised patients, ganciclovir or foscarnet can be considered. Okay, this is my reference. That's all from me. Any question?
Any questions from the floor? Faham lah ke dah? Ini patut simple lah. Ini patut easy. Rosella infantum. I've shared in the chat some reading material about the 6 disease, first to 6 disease. So these are all basically the types of fever with rash, exanthems. So exanthem means rash. Usually it's viral type of rash. But anyway, you can go and read about it. Okay, all right, proceed next.
Next will be about measles, mumps, and rubella. So next, Azim. Okay, when we talk about measles, mumps, and rubella, these 3 combination, we might be thinking of this one vaccines, what we call as MMR vaccines. Because with these MMR vaccines, it very productively reduced the infectivities of these 3 infectious disease, which is measles, mumps, and rubella. Measles vaccine is given on the 6th month of age, specifically in the endemic area, such as in Sabah, for measles only. And a combined vaccines of measles, mumps, and rubella is given on 9th month as the first injections, and also second injection on the 12th months, and there will be a booster on the 7 years of age. They are given intramuscularly. Okay, next. So let's talk about measles. Measles is also known as rubiola. We call it in Malay as demam campak. It is very highly contagious without the protections of herd immunity or MMR vaccines. And especially in those of low-income countries that do not subsidize vaccine, they can cause a very huge spread of measles so easily between the children, and they cause outbreak. And our concern is that they will be having higher possibilities of child to be to death, to end up with death due to just measles. So measles is being characterized as diseases with typical prodrome, and typical prodrome with few of photognomonic features. We will talk about it later, and then it is followed by a maculopapular rash. So basically, measles, it comes from a paramyxovirus or Paramyxoviridae family, and specifically the genus is a mobilivirus type. So paramyxovirus, it's a single-stranded RNA with an enveloped lipoprotein. So an enveloped virus is actually a fragile type of virus. And paramyxovirus, this paramyxovirus, it has a single serotype in which once infected to the persons, it will have a very lifelong immunity. So the characteristic of rash is that it spreads from below the ears and then it spread downward to the whole body. If it's upward, it spread to the face. However, recently in Malaysia, there is an outbreak of measles that happened to be at the Orang Asli settlement in Kuala Koh, Kelantan. Hazim, next. So it ended up with 12 deaths of Orang Asli children due to the outbreak that happened recently in Malaysia. Next. So let's talk about the pathogenesis of measles. So in paramyxovirus, morbillivirus type, they have hemagglutinin, they have fusion, and also they have neuraminidase, but of less functions. So in measles, this hemagglutinin, a binding protein, they will get into the epithelial cells, receptors, and infect our respiratory tract epithelium. It started off with spreading to the lymphatic area, and it gets into our blood, causing viremia, and it infects our reticuloendothelial cells and cause further infections to the blood. And as far as where the blood goes, so it causes wide disseminations to all the other areas of our body, especially at the skin vascular endothelial cell, at our blood vessels, in which it causes inflammatory reactions to appear, and vascular permeabilities causes vascular permeabilities. That is the reason why in measles there is appearance of rash. Next, let's look at the clinical features. Okay, measles, the incubation periods is like around 2 weeks, 8 to 14 days, and it has two distinctive important phase, which is an infectious phase and also a non-infectious phase. So infectious phase is a phase where it is of a catarrhal stage, a stage where a person got coryza, cough, conjunctivitis, and also fever. This is the phase where people might be having runny nose. Okay. And also non-infectious phase is an exanthematous phase where maculopapular lesion or rashes started to appear. So in catarrhal stage, like what you see in the table, they also cause one photognomonic symptoms, which is an enanthum. Okay, there is difference between enanthum and exanthum. Enanthum is where there are eruption or rash eruption that appears within the mucosal surface, but exanthum is rashes that appears out of the mucosa or out of the body, such as in our skin, like maculopapular rash. So enanthum is the enanthum is the coplic spot, where it is a tiny white spot on erythematous base. You can look at the picture. It happened to be at the buccal mucosa on day 2nd and day 3rd of clinical illness. Okay, it fades as cutaneous rash appears. So basically, children come to doctor when they already have rashes on their body. A lot of times, doctor might be missing this signs because it already disappeared as the exanthematous rash appear. Okay, next. Okay, let's talk about the non-infectious stage. So within this non-infectious stage, there is a discrete erythematous maculopapular rash, and it started off at the neck or specifically below the area and at our hairline. It spread downward through the trunks, limbs, soles, and palms. It also spread to our face, upward. And then the tendency of rash shows confluent and blotchy type of rash. So basically, blotchy is when there is like some pigmentations, and confluent is when these rashes, they comes together, they comes in group. Yeah. And eruption begins to fade, and will disformate and become pigmented at the end of their phase, exanthematous phase. So in order to get a full view or the full what we call it stages, let's look at our next slide for better understanding. Okay, so in incubation period, yeah, once the virus enter, it could be in incubation period for about 2 weeks, and there we go. There is a prodromal period and also exanthematous stage, catarrhal stage and also exanthematous stage. So in catarrhal stage, they are a lot more infectious than the exanthematous phase. Okay, and there will be a recovery period. So usually it comes with, in catarrhal stage, it comes with cough, conjunctivitis, and also coryza, together with pathognomonic Koplik spore. And once they got infected, we got a lifelong immunity. Next. Okay, this is the summarization of complications and also clinical features. Next. Okay, let's talk about the complications of measles. Complication of measles, usually it is due to extension of inflammation due to the virus. And secondly, it is because of secondary infection of the damaged tissues. And third, it is because of aggravation of already existing malnutrition. So, if we take a look at the neurological systems or at the head, there is a post-infective encephalitis. This is basically due to the direct viral extension, in which in the CSF we can see there is a increased lymphocytes, lymphocytosis, and also pleocytosis. So they can give a lot of neurological symptoms. And then in otitis, sorry, they have wrong. This is wrong spelling, my bad. Otitis media and also mastoiditis. This is because of infections, secondary infections to the middle ear. And SSPE. SSPE is subacute sclerosing panencephalitis. There's also misspelled. Sorry. Okay, so in SSPE, it is rare. However, it is dangerous because it is a form of degenerative brain disease post infections of measles, and usually it manifests months after the infections without our realization, and averagely it can go up to after 7 years post infections of measles. Okay, in respiratory, there is bronchopneumonia, giant cell and bronchitis. In cardiovascular, there will be myocarditis, and yeah, you can read by your own. Like pregnant mother, they can have spontaneous abortion and also preterm delivery. Eyes, then there will be keratitis and corneal scarring, blindness, and hematological. It can cause hemorrhagic measles and also thrombocytopenia.
Sorry. Just want to highlight you. We've had, I think, was it last year? I think last year, if I'm not mistaken, we've had a child who died in our hospital, where the sibling died recently because of subacute sclerosing panencephalitis as well. So it is not that uncommon. It's not that uncommon, this problem. And obviously, we've seen, I've seen children becoming severely ill because of pneumonitis, because of measles pneumonitis. We've seen children becoming severely ill because of measles encephalitis. So as uncommon as we thought. Okay, all right. Oh, ramai pula left ni.
Thank you, Doctor. So this is not so common. Okay, so next. Okay, investigations. Next. Azim.
Mana Hazim? Ke Hazim dah terkeluar dah? Ada lagi Hazim? Mana Azim?
Okay.
Mana Azim ni? Macam mana ni? Okay, let me do something. Let me do this. Sorry. Okay, wait. All right. Anyone else has the presentation in their slide? If not, I'll use mine. Okay. Okay lah. Let me project. Where is the option? Okay. All right. Where are we now?
Yeah.
This one.
Investigation. Okay, for investigation, usually measles is a clinical diagnosis, or we can also do serology and also polymerase chain reactions. As for management, in management, measles requiring hospitalizations and also isolations, and it needs just a symptomatic management. There is no any antiviral therapy, but yet else what we do is that we treat them symptomatically, giving them antibiotics for fevers, and also give them any other dehydration, such as examples. So in developing countries, we give them vitamin A in order to modulate their immune response. As for in Malaysia, we have a prevention of measles by giving them vaccines, as what I told my friend earlier. Okay, next. Okay, let's talk about mumps. Okay, mumps is in Malaysia. Next, doctor. Okay, in Malaysia, mumps is also known as beguk. So it is highly contagious infection to the parotid gland, where it results in swelling of the salivary glands. It is self-limiting, but however, it can cause such a complication such as there is painful in our neck area, and it's causing hard for these patients to eat and sort of to eat and move their neck. And another complication that it also can cause infertility. So later we can talk about it. So yeah, next, pathogenesis, paramyxovirus. It is caused by paramyxovirus, in which the viral they enter our respiratory tract, and virus they grow in our salivary glands and also lymphoid tissues. It's spread to the spleen and also distant areas and to the whole part of the body as it gets into our blood. Next. Okay, this is how we should explain in a word form. Next. Okay, for clinical features, the incubation period is usually of 18 days, and the period of infectivities is 7 days. Cutoff point is during the inflammations of parotid gland, 2 or 3 days before the onset of parotitis and also 3 days after parotitis. So prodromal symptoms similar to other viral disease, viral fever with fever disease. However, there is earache and also anorexia and also trismus, which is pain on eating and drinking. That's the reason why patient got anorexia. So signs, there is an enlarged inflamed parotid gland in which it is unilaterally and initially reach at its maximums, and it often displays the earlobe once it becomes very big. And then there will be the skin of the infected parotid gland. There is sign of inflammation, which is there is edematous, warm and tender, and especially at certain ducts. This is what we call Stenson's duct and also Wharton's duct. There is the picture I already provide, you can see. Okay, next. These are the symptoms that we look for in physical examinations. Okay, next. So complications, there will be meningoencephalitis, myocarditis, hepatitis, pancreatitis, orchitis, and also epididymitis. It can cause infertility because of fibrosis of tunica albuginea, in which it resists the expansion and cause pressure necrosis of the spermatocyte. That's the reason why a patient got infertility. Oophorytis, arthritis, and also mastitis is also another complications of mumps virus. Next. Okay, what we can do for mumps in investigations of mumps virus, it's usually of a clinical diagnosis, but we can do some blood tests for antibody and also viral culture. We can get this virus from our blood, from the urine, nasopharyngeal aspirate, throat swab, buccal swab, and also CSF. So basically what we do as a future doctor, we symptomatically manage these patients by giving pain relief with analgesic, nutrition, bed rest. We have no antiviral therapy, but we have prevention. We're responsible to give MMR vaccine. Okay, next. We're done with measles. Let's talk about rubella. So rubella, it is also known as German virus. Sometimes we get confused. Rubiola causes measles. Rubella causes German measles. So it affects school-age children, adolescents, and young adults. It is from a Togaviridae family. Previously, it's a paramyxovirus family, but this one, rubella, it's a Togavirus family. It can transmit via respiratory droplets and also transplacentally. It is single serotype in which once we got infected, we got a lifelong immunity once our antibody recognized these diseases. It will infect the nasopharynx and also lymph node, causing viremia and widespread disease, and it also causes rash. Next. Okay, clinical features, the incubation period is of 14 to 21 days, and infectious is from infectious stage, or infectious time is from 1 week before and also after the rash. It is quite similar with the other diseases, but the differences that we can have conjunctivitis, babies or and also the mothers can have conjunctivitis. There is what we call as Forshemer spot. Forshemer spot is a suggestive of rubella. It is not definitive. It is particular lesions on the soft palate. Lymphadenopathy at the suboccipital, post-auricular, and posterior cervical group. It has maculopapular rash and also splenomegaly. Okay, next. So this is the area that we try to look for. Suboccipital, post-auricular, and also posterior cervical group. Okay, this is the complication. And we got encephalitis, myocarditis, arthralgia, and also thrombocytopenia, purpura, or hemorrhagic manifestations. Okay, let's talk about congenital rubella syndrome. Next, in our next slide. Okay, congenital rubella syndromes. It is when a non-immunized pregnant woman being infected during their first trimester, specifically at the first month of pregnancy. It can transfer to the baby transplacentally, and the virus will reach the fetus via emboli of infections endothelium. It can cause rapid death and also persistent infections because it damages all the germ cell layer as the baby is trying to grow within the pregnancy period, and because it also impaired the cell divisions, and it caused malformations as a result of fetal and also maternal viremia. So next, we can see the classical features of rubella. There is a classical triad, which is microcephaly. There will be cataracts and also congenital heart disease, which is specifically patent ductus arteriosus. Okay, some comes with mental and also growth retardation and also sensory neural deafness. So what we can do to prevent the babies, from getting infected is that we need to give MMR vaccine to all school children. So investigation to detect patient with rubella is that clinical diagnosis with antibody titer. So there will be an IgG rise 4 folds than normal, tissue culture, PCR or viral isolations, and also in congenital, we try to look for IgM in fetal blood, viral isolation or PCR within the amniotic fluid of the baby, of the fetus. So management is symptomatic treatment. There is no antiviral therapy, but we give rubella vaccines for them. Okay, that's all. My pictures after this is just to differentiate rubella, rubella, and also roseola infantile. Next, same goes to the next picture. Okay, that's all from me. Is there
Any question from the group? Any question? Your group ni is cautiously very quiet. Tak tahu ada lagi ke tak ada lagi ni. Hilang belaka dah. Ha? Switch on Zoom mana pergi minum teh ke apa ke mana pergi semua. Just to highlight few things. So first, in several countries in the world, measles is almost eradicated. For example, in US in 2012, they almost declared measles as eradicated from US. But then I think I don't exactly remember. I think was it in 2014 or 2013 or 2014, they have the Disneyland measles outbreak. So what happened was one of the anti-vaccination groups, the child was having early symptoms of measles, and then obviously they brought their children to Disneyland. So from that index case, hundreds of Disneyland visitors in United States of America got measles. So and it involves multiple states as well. So this basically caused problem with their control of measles. And in Malaysia, I've mentioned before, we've seen sporadic cases. And the thing is, sometimes every few years we'll have this outbreak of measles. Like recently in end of 2019, second quarter of 2019, the Kuala Lumpur outbreak, 15 deaths because of measles. And I think we've seen before, sometimes our PID ICU was full with children ventilated because of measles. So this is not a simple disease, it's a complicated disease. I've seen children become blind due to congenital rubella. So these are all not simple diseases. Okay, let's go back a bit. When is MMR vaccine introduced in Malaysia? So MMR vaccine introduced in Malaysia in 2002. Measles vaccine. So we started initially with measles vaccine. That was in 1982. I was just 1 year old at that time. So Malaysia introduced measles vaccine in 1982 and rubella vaccine in 1986. So initially we only give measles vaccine, we only give rubella vaccine in 1986. So in 1986, what happened was, we did not give rubella vaccines to everyone. We only give rubella vaccine for female at around school age. I think was it 12 years old or something, we give rubella vaccine. So only for girls at around 12 years old, 12 or 15, probably 15 years old girl, we give rubella vaccine. So that was the initial phase, because you know, rubella, if you get German measles, the symptoms sometimes are not that severe, unless if you are a very small child, unless if you're immunocompromised, unless if you're from the high risk groups. Otherwise, symptoms are generally mild. So we only give to girls the rubella vaccines. Okay, so what happened when only girls get rubella vaccine? Okay, girls are protected against rubella disease. But as you remember, vaccination, even though it is highly effective, the problem with vaccination is that they are affected by cold chain. So how you transport the vaccine, if you don't properly protect the vaccine against heat, so the vaccine may be inactivated. the vaccine may also be affected by technique of giving the vaccination. The vaccine may be affected by so many other things as well. So, and then when we have rubella in the community, because males, they are not vaccinated, so the rubella disease is still in the community. So what happened was, and especially remember when girls, when female are pregnant, pregnancy causes a relative immunosuppressive state. So when you're pregnant, you are more susceptible for viral diseases. So this is the problem. When males are not vaccinated, the disease is still in the community, and female, when they're pregnant, being relative immunosuppressed, they can get rubella. And sometimes for the mother are protected because they are vaccinated. They don't have severe rubella disease, but they can still transmit the disease to the baby. So, and this causes congenital rubella syndrome, which we do not want. So the decision at that time was to give MMR vaccine to all children. So all children at the age of 12 months old gets MMR vaccine. And now, because we still have so many outbreaks, we give 2 doses of MMR in areas where we still have many measles cases. We give at 6 months, and then generally in Malaysia now, I think since 2018, since quite recently lah, we do 2. We do in at 9 months old and at 12 months old. So before it's only once. This is MMR. And another thing about MMR, so anti-vaccination movement. Okay, I have a full presentation about this. So anti-vaccination movement starts by a lie about measles vaccine, about MMR vaccine. So there was this author, what's his name? I don't remember. Andrew. Let me see. I have a slide about this. So there was this author, Andrew Wakefield. So Andrew Wakefield wrote a paper in Lancet. In which year was this? In, I think, was it 2004? So Andrew Wakefield in 2004 wrote a paper saying that MMR vaccine is associated with autism. So he wrote a paper in Lancet saying that MMR vaccine causes autism. Why? Because of this mercury content. Mercury content in the vaccine, which is thimerosal. So thimerosal is one of the basically it's a mercury substance. So thimerosal is a mercury substance. So he claimed that mercury in the form of thimerosal causes autism in children who were given MMR vaccine. So he published that paper in Lancet, and this is the first basically paper that says that vaccination causes autism. So it causes a wide spread, it become very viral, and many people, even until nowadays, people reject vaccination because they say it causes autism. And then when we go through, actually this Dr. Andrew Wakefield sekarang ni, he's been his license has been he's been delicensed. The license dia dah kena tarik balik. License to practice has been pulled. Why? Because actually he lied on this. Obviously bila ada vaksin kan, ada banyak company yang nak jual vaksin. So US at that particular time, they bought this MMR vaccine from one company. So what happened? The rival company paid Dr. Andrew Wakefield to actually publish a paper. So Dr. Andrew Wakefield, gaining lots of money from this rival company, wrote a paper claiming that this MMR vaccine from this company has thimerosal, which causes autism. And when we look at it, actually, all the cases, it's a very small number of cases that they report, I think 20 something. And those cases are fictitious cases. Dia create, tak ada patient pun, dia create sahaja. and this paper has been pulled out by Lancet, and he has been his license has been pulled as well. He doesn't have any license to practice as medical doctor, but his study has been quoted, has been used as evidence by all the anti-vaccination group. So this shows how severe and how serious the problem with anti-vaccination, and how serious the problem with lying on a research paper. So just to highlight some issues, I hope you guys will have a lecture. I think in year 5 we'll have a lecture about immunization. Okay, all right, proceed next.
I will be presenting regarding varicella, chickenpox, and herpes zoster, which is shingles. So varicella-zoster virus is a human alpha herpesvirus 3, usually referred to as the varicella-zoster, and it is an enveloped double-stranded DNA virus, one of the 9 herpes virus known to infect humans. Varicella-zoster virus causes both chickenpox in children mainly, and also shingles in adults. And the transmission occurs through the airborne, direct contact, or vertical transmission through the placenta. When the person first infected with varicella-zoster virus, he or she will get primary infection, which leads to chickenpox or varicella. And when this virus establishes latency in dorsal ganglia after primary infection, the reactivation can cause herpes zoster or shingles. For epidemiology, varicella-zoster is endemic and it causes primary infection, which is chickenpox. The manifestation is classic papulo-vesicular exanthematous disease of the childhood, and the highest prevalence in the pre-vaccine era is 4 to 10 years old. However, with introduction of vaccine, the prevalence is 10 to 14 years old, and it is highly contagious. For herpes zoster, it is sporadic and secondary infection with highest prevalence in older adult, more than 50 years old, with the risk factor of increasing age and immunosuppression. So these are the pathophysiology of varicella-zoster. When there is inhalation of the infectious respiratory secretions or by direct contact with skin lesions, because the transmission is by inhalation or direct contact, the virus will be deposited at the conjunctiva and respiratory mucous membranes, and this virus will undergo first cycle viral replication in the regional lymph node, resulting in primary viremia. This occurs by the day 4 to day 6 of illness. And then this primary virus will travel to reticular endothelial cells in the liver and spleen, performing its second replication, resulting in second viremia. And this secondary virus will invade capillary endothelial cells and then spread to the epidermis by day 14 to 16. After that, the body's immune system will limit viral replication and facilitate recovery, and this virus will travel via sensory axons to dorsal root ganglia and remains dormant. For clinical manifestations of varicella-zoster or chickenpox, the incubation period ranges from 10 to 23 days, and the illness usually begins 14 to 16 days after the initial exposure. And the period of high contagious is 1 to 2 days before onset of rash until lesions have formed crust. And the prodromal symptoms occur 24 to 48 hours before rash. The symptoms are fever, malaise, anorexia, headache, mild abdominal pain, and the rash. The typical rash is papular vesicular rash, which begin on scalp, face, and trunk. It is initially pruritic, which is itchy, erythematous macules that evolve through the papular stage to form clear, fluid-filled vesicles followed by crusting. Other than that, patient also will have some of patient will develop generalized lymphadenopathy. Among the complications of varicella-zoster, most common in children is secondary bacterial infection of skin lesions. However, in adult, the complication is pneumonia. Another complication is Reye syndrome. It is a rare but serious condition causing swelling in the liver and brain, and most often affects children and teenagers. Other complications include neurological, which are post-infectious encephalitis, cerebral ataxia, and nystagmus. Next slide. For herpes zoster, which is shingles, it is caused by reactivation of the dormant herpes varicella-zoster virus. For the clinical features, it causes in the pre-eruption phase, it will cause intense localized constant pain and tenderness along the dermatome. This is what differs it from the varicella-zoster, where in chickenpox patient has itchy rashes, but in herpes zoster patient has painful rashes. The rashes will accompanied by malaise and fever, and the growth of lesions occur 1 to 7 days and progress to crusting and healing, and usually affect only a single dermatome of the skin. Compared to the varicella, it is generalized rashes. And the lesions also accompanied by regional lymphadenopathy. If you look at the picture, the rash will begin to develop, often causing pain, sometimes associated with itching and tingling sensation. And then the rash will develop fluid, and the fluid, and at last the fluid blisters will be open and cross over in 7 to 10 days. For the complication of herpes zoster, it can cause a Ramsay-Hunt syndrome, also known as herpes zoster oticus. It occurs when the zoster virus outbreak affects the facial nerve, which is cranial nerve 7 near the ears. In addition to the painful shingle rash, it can cause facial paralysis and hearing loss in the affected ear. Next is ophthalmic zoster. It affects the trigeminal nerve and causes ocular complications such as rash on the forehead, swelling of the eyelid, including pain. And the most common complication of herpes zoster is postherpetic neuralgia. It affects the nerve fibers and skin, causing burning pain that lasts long after the rash and blisters disappear. It is common in elderly but uncommon in children. For investigations, the clinical presentation of varicella or zoster are so characteristic. It means we can, from the clinical examination, we can diagnose varicella or herpes. That laboratory confirmation is rarely required, and sometimes it is only required for a typical presentation. One of the investigations can be done is virus isolation, which is the culture, but it is rarely done as we have to wait for 2 to 3 weeks for result to come out. The second one is direct detection using the immunofluorescence of the skin scrapings. It will detect the antibody against the virus. And then the serology, the presence of varicella-zoster virus, IgG or IgM. And the last one is PCR, polymerase chain reaction. For the treatment, varicella and herpes is usually self-limited and usually requires no treatment, but we can give symptomatic treatment for varicella, which are antipyretic and careful hygiene, and early therapy with acyclovir antiviral to immunocompromised patients and those at risk of severe varicella should be given. And when we give antiviral treatment for zoster, it will improve the cutaneous healing, faster the resolution of acute neuritis, and reduce the risk of post-herpetic neuralgia. And according to International Herpes Management Forum, antiviral treatment should be given to all patients above 50 years old with shingles. We can give oral or topical acyclovir to patients with herpes zoster. We can also prevent varicella-zoster. There are available varicella vaccine in 2 doses, obtained for the first dose at the age of 12 to 15 months old, and the second dose obtained at the 4 to 6 years old.
Any question? Any question? Okay, I would like to ask the presenter. Okay, you know, herpes zoster is the presentation of reinfection with varicella-zoster, isn't it?
Yes,
Okay,
reactivation.
so my question: if you vaccinate, then you get varicella infection. Will you get herpes zoster? Correct, because when you're vaccinated, your body will produce the immunological response, isn't it?
Yes.
And be protected. Okay. So if you get chickenpox once, you are basically protected for life. But if you somehow get reinfected and it reactivated, you'll get herpes zoster, isn't it? Okay.
Yes.
So the question is, how about vaccination? So you are protected from varicella-zoster, but will you get herpes zoster?
I think the patient will protected against varicella-zoster only.
So basically, if you are given, so studies have shown if you're given varicella vaccine, Varivax, and the brand to Varivax, so you are actually protected against varicella-zoster and also herpes zoster. So that's one thing. Okay. All right. So you're protected. The answer is you're protected. Second, the myth in Malaysia is that if you get herpes zoster and it goes throughout your dermatome, it will cause death. Is it correct? Betul tak? Orang Melayu punya cerita kan? Apa orang Melayu panggil? Shingles apa? Shingles apa? Orang Melayu panggil apa?
Kayap.
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 Kalau kena kayap, dia ni it's cause death. Is it true? Sudah. So that's not true lah. So basically that's not true. Okay, so herpes zoster can cause death by encephalitis and something, but the risk of death with herpes zoster is low. Okay, varicella zoster, chickenpox. So chickenpox, we think many of us think it's a mild disease. In among the anti-vaccine, I always speak about anti-vaccine. Among the anti-vaccine community, especially in America, what they do is they have chickenpox party. So when one of their group has one of their group's children has chickenpox, so what they do is they announce to all the anti-vaccination group, and then they'll organize a party so that all their children will get varicella-zoster. Isn't that crazy? That's crazy, isn't it? So this is what they do. Okay, the thing I want to say is, so if you are an adult, if you are immunocompetent, if your immune system is strong enough, if you are physically fit enough and you get varicella-zoster, okay, fine, it won't be that severe to you. But even that, you'll feel malaise, you'll feel very high grade fever, you'll have arthralgia, you have myalgia, you'll feel miserable. But it's not that severe. The problem is when you are immunocompromised. So the mortality rate for varicella-zoster in people who are immunocompromised is up to 30%. So 30% mortality rate is high. 30% mortality rate is much higher than COVID-19. So the mortality rate is very high. I've had my patient who died because of varicella-zoster. I've had one child, a 9-year-old Malay girl, down with acute lymphoblastic leukemia. The child was recovering well, was in remission, but is still on chemotherapy. And then the child contracted varicella-zoster. The child got chickenpox. What happened? She died because of varicella-zoster. And this is a very good child, among the best patient I've ever treated. Because this 9-year-old girl, she was among the few who actually always pray on time, always solat on time. You can see her pagi-pagi subuh on time, bangun sembahyang subuh. This is she was diagnosed at 8 years old. She died at 9 years old. At 8 years old, tak tinggal solat 5 waktu. was very good. She even get some of her friends in the in the oncology ward to come and pray with her. And at 9 years old, she contracted varicella-zoster and she died because of that disease. So this is a problem. And I've told you, mortality rate is 30%. I've had babies who got severe varicella-zoster disease. Mother who got varicella-zoster, mom is immunosuppressed, but usually mom also is not that severe. The problem is congenital varicella-zoster. So this is a problem. A newborn baby with varicella-zoster, 30% mortality rate. So what's the problem? So if a mom had varicella-zoster, when the child is born, what we need to do is we'll give immunoglobulin. We'll give immunoglobulin to the child. And then not just that. So if the child is symptomatic, if the newborn baby is symptomatic, so first we give varicella-zoster immunoglobulin, varicella-zoster immunoglobulin. But the problem is varicella-zoster immunoglobulin is not available widely in Malaysia. Not all hospital has varicella-zoster immunoglobulin. UIA don't have varicella-zoster immunoglobulin. HTAA doesn't have varicella-zoster immunoglobulin. Hoshas, Temeloh don't have varicella-zoster immunoglobulin. HUSM Kubang Krian don't have varicella-zoster immunoglobulin. HRPZ2 Kota Baru don't have varicella-zoster immunoglobulin. Many hospitals in Malaysia do not have varicella-zoster immunoglobulin. So what we do, we have to give a generalized punya immunoglobulin. So we give human immunoglobulin, which is not the best immunoglobulin to give. So we give varicella-zoster immunoglobulin. And when if the child is symptomatic, if the baby shows some lesion, we need to start treatment as well. So we need to start IV acyclovir for 14 to 21 days. I have seen children with varicella encephalitis in UIA itself. For the past 2 years, I think we've had 3 or 4 varicella-zoster encephalitis. So these are not simple and easy disease. This is a very complicated disease with high mortality and morbidity rate. So this is something that you all need to know. Another thing is, so can you imagine if one children, for example, in what I've had in one of the hospital in Temeloh, when was it? That was in 2015, if I'm not mistaken. So what happened was, one mother, so mother was a bit feverish, and then mother gave birth to her child. 2 days after delivery, mother starts to show the varicella-zoster punya blister, vesicles. So mother had chickenpox. Baby is already born. Baby is even admitted in our NICU. So what's going to happen? Baby is exposed already. So we need to start immunoglobulin on the baby. And then that baby starts to have the chickenpox blister. So we start treatment for the baby as well. But the problem is we don't know that the mom had chickenpox. So what happened was one of the nurses got chickenpox and several babies as well starts to have chickenpox. So we need to call all the babies within 14 days because the incubation period is up to 14 days. We need to call all the babies that has contact with the baby and also the specific nurse, all need to get immunoglobulin. And immunoglobulin is expensive in Malaysia. It's expensive. One vial, I think, few thousand ringgit. So we need to call all babies. So how many babies we need to call? And you know, in Pahang, we have communities from orang asli who lives in jungles. Very difficult for them to come and things. And it caused a huge outbreak, and that was a huge problem for us. And how about if the patient is in centers such as UIA, where the patient needs to pay, they need to pay hundreds and thousands of ringgit because of that. And this causes money, this causes financial constraint to the ministry and to the taxpayer. So this is a huge problem. Okay, all right, next, last presentation.
Okay, Bismillahirrahmanirrahim. Can you guys hear me?
Yes.
Yes. Yes.
A very good morning, I bid to all of you. So it comes to my part, which is the last part of this seminar. I will be presenting about HFMD, or we call it as hand, foot, mouth disease. Okay, before that, we need to know the definition of HFMD. Based on the illustrated textbook of pediatric 5th edition, HFMD, or hand, foot, mouth disease, is a painful vesicular lesions on the hand, feet, mouth, tongue, and often also on the buttocks. However, based on other definition, based on up to date, it is a clinical syndrome characterized by oral enanthum and macular, maculopapular, or vesicular rash of the hands and feet, and possibly on other locations. Okay, HFMD is a common and self-limiting illness. It occurs worldwide, and the outbreaks involving daycare centers, schools, hospital wards, and community have been reported. And there is also intra-family spread among the family in HFMD. Most cases of HFMD occur in infants and children, particularly to those younger than 5 to 7 years old. And it is usually occur during summer and early autumn. However, in tropical country, most of the cases occur during the rainy season. Temperature and the humidity affect the incidence of HFMD, so it raising the possibility that the HFMD may be related to the climate changes. So in Malaysia, HFMD is an endemic disease. It has become an important public health concern due to its tendency to cause a large outbreaks and death among children and infants. Okay, next. Okay, this is a graphic that show in 2018 with this there is a large outbreak of HFMD. Based on this graph, it shows that from January to July 2018, it is being reported about 33,000 of cases of HFMD has been reported. Next, and by the mid of August, the case are raising up to 51,000, and one mortality has been reported in the Sarawak. Next. Okay, for the etiologies, HFMD is caused by human enterovirus, such as the example of human enterovirus are poliovirus, ecovirus, Coxsackie A and B virus, and also enterovirus. And for HFMD, Coxsackie virus A16 is the most common causes. Its clinical cause usually mild with full recovery. However, HFMD caused by enterovirus A71, only 71, can be more severe due to higher incidence of neurologic involvement, such as meningitis, encephalitis, and also neurologic pulmonary edema. And the other strain are Coxsackie A5 anti-10, and so Coxsackie B2 and 5. Next. Okay, for the mode of transmission, HFMD is moderately contagious, and a person is most contagious during the first week of illness. And the incubation period for the HFMD, based on the Malaysia guideline on HFMD, is about 4 to 6 days. However, it can be short as 2 days and as long as 7 days, based on the up-to-date. It can be spread via nose and throat discharge, saliva, fluid from blisters, stool of infected person. So basically, it is a fecal oral transmission. Okay, for the pathogenesis of HFMD, okay, human enterovirus infection occurs after ingestion of virus that is shed from the gastrointestinal or upper respiratory tract of infected individuals. Once ingested by the person, the enterovirus replicates in the submucosal lymphoid tissue of the lower intestine. So following the replication of the virus in the submucosal lymphoid tissue, the enterovirus spread to the regional lymph node, and replication at this site, which is the regional lymph node, will result in minor viremia that disseminate virus throughout the body. And this will result in infection of reticular endothelial tissue and multiple organs such as central nervous system, heart, liver, and skin. So this replication will lead to the clinical manifestation of the patient. And further replication will lead to major viremia. Okay, HFMD typically presents with mouth or throat pain, which is in a verbal child, or refusal to eat in the non-verbal child. Fever is present, if present, generally below than 38.3 degrees Celsius. And the patient of the child might have abdominal pain, diarrhea, vomiting, headache, malaise, injected conjunctivitis, and also rashes or lesions. So for the lesion, it may be oral enanthum or exanthum. Next. This is some picture of the oral enanthum. As we mentioned by Adha before this, the definition of enanthum, exanthum. So the oral enanthum, it is most commonly on tongue and mucosa, less commonly on soft and hard palate, and occasionally at alveolar lips and tonsil. Okay, for the oral enanthum, it is usually begins as erythematous macules, which progress to vesicles. Then it quickly rupture and lead to formation of superficial ulcer. Next is exanthum. Next, doctor. Okay, exanthum. It can be maculopapular, or vesicular form. It is commonly found on the hand, feet, arm, legs, and buttocks. It less commonly on the face or torso. Exanthum is for the HFMD is non-pruritic, and it is usually non-tender and can resolve within 3 to 4 days. For the complication of the HFMD, complications are more common by enterovirus 71, and for the serious complication, as I mentioned before, it can only rarely occur except in HFMD, and it has been reported if the HFMD that are caused by the Coxsackie A virus 16, based on the journal, it is reported only 3 fatal cases that caused by the Coxsackie A16. But in the enterovirus 71, it is more severe. The example of the complication is dehydration, aseptic meningitis, rhomboencephalitis, which is brainstem encephalitis, acute paralysis, finger or toenail loss, onychomatosis, myocarditis, and pericarditis. Pancreatitis, fetal loss, and conjunctival ulceration is usually rare. Okay, diagnosis for the HFMD is usually made clinically, and the laboratory studies are usually unnecessary. But if it is uncertain or the doctor need to know specific viral etiology, such tests can be done, such as throat, stool, and vesicular fluid sample taken for the NAAT, nucleic acid application test. Stool specimen that can be used to detect the viral. If the patient is complicated with the meningitis and to rule out any other disease, we can do lumbar puncture, and biopsy also can be done. As for the differential diagnosis, it can be aphthous ulcer, primary hypersymplectic gingival stomatitis, varicella, ID reaction, contact dermatitis, erythema multiforme major, eczema hepaticum, and also insect bites. Okay, this next is some picture of the differential diagnosis, which is varicella, erythema multiforme major. So as you can see, there is a little bit difference based on each diagnosis. Okay, for the management or treatment, HFMD, as I mentioned before, is a mild clinical syndrome. So complete resolution can be achieved typically within 7 to 10 days. However, complication can occur. So for the management, in the slide, as you can see, it is mainly supportive. Most of the cases do not require hospital admission, but children with complication may require admission. So if the patient has a fever, you can give an antipyretic. If the patient has a severe dehydration, you can start with the fluid therapy, and most of all, the children need good rest. Okay, indication for hospitalization. So a child is indicated for hospitalization when the child is unable to tolerate oral feeds and when there is need for IV hydration, when the child is clinically very ill or toxic looking, when there is a suspicion of neurological complications, when there is a suspicion of cardiac complications such as myocarditis, or indication also hospitalization also can be indicated for when the parents are able to cope with the child illness, or when there is inadequate family or social support in looking after the child at home. Next is prevention. So For the hygiene, we need to educate the child and the parents to practice a good hand hygiene to prevent the spreading of the HFMD virus. And also its isolation. A person that is infected with HFMD or by the virus or have been diagnosed to have HFMD should be isolated. Contact precaution and standard precaution should be practiced when handling the patient. And that's in health education, especially for the parents. They need to be educated what need to be done when their child is infected with the HFMD disease. Vaccine, which is this one is not yet available. And for the prognosis of the HFMD, it is basically excellent. Patient with the HFMD basically have a excellent prognosis. As I mentioned before, it completely resolved within a few weeks, and HFMD rarely recurs within the same patients. Okay, that's all from me, and this is my references.
Presenter.
Yes.
I just want to ask you, what is this number 4? What is that?
Wait a minute, I forgot.
This is id reaction, id reaction.
Oh, reaction.
So it's not ID, it's id reaction. So basically,
Okay.
it's a form of more severe eczematous reaction. So disseminated eczema, some that sort. So basically, it's an inflammatory reaction causing more severe, more generalized eczematous lesion. Okay, so HFMD basically in Malaysia is quite common. We always see children with HFMD. Again, it's caused by Coxsackie virus. I think around 10 years ago when I was a medical officer, we do send stool sample, rectal swab for Coxsackie virus. But then now it's mainly clinical diagnosis. And basically children now shouldn't die because of HFMD. So mainly they die because of dehydration. Mainly they die because of dehydration. Very rare, it can meningitis, encephalitis because of HFMD can also cause death. Myocarditis can cause death as well. But majority of the death is actually because of dehydration. So especially in underdeveloped countries where they don't have access to good healthcare, many people still live in areas which are inaccessible to healthcare facilities, so they may die because of dehydration. Children in Malaysia shouldn't die because of HFMD. So this is one thing. If they don't get the complications such as encephalitis and so on and so forth. But there's no specific treatment. Okay, all right. Any other questions? Any question? Clear? Faham belaka? Okay. Tanya presenter.
Does reactivation and reinfection is the same? Reinfection.
So you can get you can get
reactivation of virus and second
So you can get, so reactivation can also mean several things. Reactivation, so reinfection where the infection has settled and then you get infected again. So that is reinfection. Reactivation, it may mean a reinfection with the disease, but it mainly mean that there is still viral inside your body. So just reactivation of the dormant viruses. So it can mean that as well. Okay. Clear? Okay, one thing before we stop. I noticed that many of you sometimes left the group. I presume this is because probably poor internet connection or something. So sometimes if you're being kicked out of the group, probably you have patchy internet connection. And I saw many of you as well, like me, don't have camera. I don't know why my camera all don't work now. But anyway, probably that is because of poor internet connection as well. So these videos are all are going to be uploaded in our IIUM pediatric department YouTube channel. So please view them, and because these are things that may come in your exam as well. Okay, all right. Clear? let's end our session with tasbih kafarah. Okay, Assalamualaikum.
Thank you, Doctor.
Salam, thank you, Doctor.
Thank you, Dr.
Thank you, Doctor.